But nevertheless, we have Dr. Alia presenting pulp therapy for primary and immature permanent teeth. So Dr. Alia, please do introduce yourself to us, and this stage is all yours. Thank you.
Okay. Hi, everybody. Good evening, and thank you so much for being here with us. And I'm sorry that we are late a little bit. My name is Alia Abdul Majid, and I am an associate with Tooth Corner. I graduated from Dalhousie University in 2007 in the qualifying program. And today I'm doing just summarizing for the article Dr. Sally sent it to us. It is the recommendation of American Pediatric Dental Association for the therapy, pulp therapy for primary and immature permanent teeth. So I just decided to put those radiograph just because it's very rare and it's very hard to accomplish that much root canal for deciduous teeth. So the primary goal of pulp therapy is to maintain the integrity and health of teeth and their supporting tissue while maintaining the vitality of the pulp tooth affected by caries, traumatic injury, or other causes, especially with young permanent tooth with immature apex. So we need to know the health status of the pulp tissue for permanent and for deciduous tooth. So either it is a normal pulp or which is reversible pulpitis, or symptomatic or asymptomatic irreversible pulpitis, or a necrotic pulp. So each one of those conditions requires specific treatment way for both permanent and deciduous teeth. And to gain the diagnosis, we need to have a comprehensive medical history. And it's very important to know if the patient has congenital heart disease or bleeding disorder, because that affects our decision to what way we are going to do either extraction or to keep the tooth with pulpectomy, for example, for a deciduous tooth. And to review past and present dental history and treatment, including current symptoms and chief complaint, and ask mother or the patient with the history of chief complaint what stimulus make it worse, what relieve the pain, and we need to do extraoral examination and intraoral examination with soft and hard tissue. Radiograph is very important, and to look at periapical and periradicular changes for deciduous teeth. Clinical tests is very important, such as palpation, percussion, mobility. However, it's very important to notice that electric pulp and thermal tests are unreliable in immature permanent and primary teeth. So for primary teeth treatments, although the basic aim of endodontic therapy in children is the same for the adult, which is the removal of infection and chronic inflammation, so to relieve associated pain, there are particular difficulties and consideration. The pulpal tissue of the primary teeth may become involved earlier in the advancing carious lesion than permanent teeth, just because of the thickness of enamel, like a small thickness of enamel and dentin, and the big pulp chamber, and sometimes with irregular horn. So it might be involved in pulp disease earlier than the permanent. And the treatment usually depends on the diagnosis itself. So for reversible pulpitis, we can use protective liner, which we can use it for both immature permanent teeth and the primary teeth. We can use calcium hydroxide and we can use MTA. And we use it just because we want to minimize injury to the pulp, promote pulp tissue healing. We can also do indirect pulp treatment. In indirect pulp treatment, when we see there is a small amount of caries which is not in the dentino-enamel junction, and the tooth is asymptomatic, so we just want to preserve the health of the pulp, and we can do indirect pulp treatment by using MTA or any other biocompatible material. Sometimes we use calcium hydroxide. However, many literatures against using calcium hydroxide in primary teeth. I don't know if as indirect pulp capping is acceptable or not. But I know for indirect pulp capping, it's just not advisable to use it. Usually for indirect pulp capping, there is two ways to do it, either to do it in one step or to do it in two steps. Nowadays, like literatures advise to do it in one step and no need to reopen again the asymptomatic tooth to remove the caries. And the caries should not be in dentino-enamel junction at all. So sometimes we prefer, or the clinician prefer to use interim therapeutic restoration. In that situation, we do mass excavation and just put a temporary filling, either glass ionomer based restoration or IRM, just to stabilize the caries, and then reopen it again and remove all the caries and do whatever necessary, either indirect pulp capping or it depends on the case and the symptoms of the tooth. For the direct pulp capping, as I said, when it is indicated only when it is pinpoint exposure, which is 1 millimeter or less, and when there is no caries around it, and usually it has success rates higher when it is only traumatic exposure or for deciduous teeth. And if there is young immature apex. So we can see here, this is an extracted deciduous tooth, and we can notice how the pulp chamber is large here, and the horns are bigger than what we expect in permanent teeth. So we said for primary teeth or deciduous teeth, we can use indirect pulp capping. We can use direct pulp capping and pulpotomy, which is the most popular treatment. In pulpotomy, we remove the full pulp chamber all the pulp tissue in the pulp chamber. And it is indicated when the diagnosis is irreversible pulpitis, or when it is reversible pulpitis, but there was a traumatic pulp exposure. And there is no radiographic sign or infection of pathological resorption. And there is no coronal, either periapical or periradicular bone loss or radiolucencies, in which the coronal pulp amputated and the pulp hemorrhage, the bleeding or the hemorrhage controlled, and remaining vital radicular pulp tissue treated with either formacrysol or MTA. Some schools just use ferric sulfate for examples, but usually if we expect the tooth to stay for 24 months, that's 2 years, we recommend to use formacrysol or MTA. And then the tooth is restored by either amalgam, composite, or stainless steel crown, depends on the remaining enamel and how many surface of filling. So if it is a 3 surface MOD, usually the recommendation is to do the stainless steel crown. I don't know if we need to go ahead and speak about the procedure, pulpotomy. It's usually, we use formacrysol for 5 minutes and we control bleeding. And then insert zinc oxide eugenol on the orifices of the canals and to restore the chamber. And then on the top of that, we use the restoration. Either we put glass ionomer cement and then composite or amalgam or stainless steel crown. In pulpectomy, it is a root canal procedure for pulp tissue that is irreversibly inflamed or necrotic due to caries or trauma. In this procedure, the canals are debrided and shaped with hand or rotary files. We use irrigation chlorhexidine or 5% sodium hypochlorite or sterile water. We need to be careful that sodium hypochlorite must not extrude beyond the apex. Resorbable materials such as non-reinforced zinc oxide eugenol, iodoform-based paste, or combination-based iodoform and calcium hydroxide is used. Zinc oxide eugenol performed better long-term than iodoform-based paste in many literatures. Clinicians should evaluate non-vital pulp treatment for success and adverse event clinically and radiographically at least every 12 months. Usually we do it in recalls every 6 months for children. And indication of pulpectomy is indicated in primary teeth where irreversible pulpitis or necrosis in the tooth treatment plan or the tooth treatment plan for pulpotomy, but then we find that radicular pulp exhibit clinical signs of irreversible pulpitis or pulp necrosis. Then we need to go ahead and do the pulpectomy. And the root should exhibit minimum or no resorption. Following treatment, the radiograph infectious process should resolve in 6 months as evidenced by bone deposition. Usually in deciduous teeth, the the radiolucencies, or the first sign of infection, will appear in the bifurcation area, which is periradicular rather than periapical area in the permanent teeth. There is a treatment which is called lesion sterilization repair, LSTR, in which no instrumentation is used in the root canal. The tooth usually is necrotic, but there is external resorption, which prevent us to in doing or in performing the pulpectomy. And the goal in this procedure to keep the tooth less than 12 months. So it's better than extracting the tooth, but the expectation is only 12 months. And there should be no bone resorption. In this procedure, we do the same procedures like pulpotomy. So we open the chamber and clean the wall of the chamber, and the orifices, the root canal orifices, enlarged so it can accept the medication, and then it cleaned with the phosphoric acid. Usually a paste of 3 antibiotic mixture, which is clindamycin, metronidazole, and ciprofloxacin, is combined with a liquid of Victor and polyethylene glycol and macrogol to form a paste. This paste placed directly over the pulpal floor, and then it's covered with glass ionomer cement and restored with a stainless steel crown. Okay, so the paste, this is wrong. So the paste used in treating primary teeth with LSTR should not have tetracycline at all. So the antibiotics should be those 3, clindamycin, metronidazole, and ciprofloxacin. Now for the immature permanent teeth, the goal is usually to leave the pulp vital as much as we can. So we usually use in big carious lesion, we usually use protective liner just to protect the pulp, as we do with the primary teeth, and to minimize pulp injury, promote pulp healing. And Apexogenesis is a histological term used to describe the continued physiologic development and formation of the root's apex. Formation of the apex in vital young permanent tooth can be accomplished by implementing the appropriate vital pulp therapy, which is indirect pulp capping, direct pulp capping, partial pulpotomy, full pulpotomy, and pulpectomy with calcium hydroxide. Lots of mistakes. So we know indirect pulp capping when we leave a small amount of caries, usually not in the dentino-enamel junction, and we use either calcium hydroxide or MTA, and direct pulp capping when there is pinpoint exposure. When the pinpoint exposure is, when the exposure is bigger than 1 millimeter, so usually we do partial pulpotomy or fixed pulpotomy, and usually we do that in permanent teeth with immature apex. So, and the procedure for that is with the sterilized round burr, we remove 3 millimeter around the exposure, which we expect this tissue is inflamed. and then either insert calcium hydroxide or NTA, and then restore the tooth. And this procedure succeeds especially when the apex is still open, it's not closed. And usually it's very important to use a slow speed and use irrigation, not from the high speed, not from the water system. We need to use sterilized water, either irrigation by a one-time used syringe, normal saline, for example. Full pulpotomy can be achieved also if we open an immature tooth, immature apex, and we find we cannot stop bleeding. So full pulpotomy is used. Procedure the same like in primary teeth. Just to notice, just to follow up with that tooth and let the apexogenesis process complete, and then we will achieve a longer route. It is better for longevity of the tooth to stay in the mouth because of a good crown root ratio. And if pulpotomy is, we cannot do pulpotomy because of the inflammation or infection in the canal itself. So we need to do pulpectomy, and we need to insert calcium hydroxide in the canal to help reduce the inflammation and infection. We usually do the procedure the same way, like we open the access opening. We do the access opening and instrument the canals, and then inject calcium hydroxide to the apex, and wait for 2 weeks, and then open the tooth again and irrigate and dry, and then insert calcium hydroxide. Some schools use it for this procedure for 1 month. Some schools use it for 3 months. And then and the final visit, just we need to check the apex with the paper point only to check if there is hard tissue or a granulation tissue. We can use our tactile sensation, and if there is hard tissue, then we can insert NTA 2 millimeter less than the working length, and then fill the restoration, do the obturation as normal. And that's all for my presentation for today.
Thank you, Dr. Alia. I'm sure everyone really enjoyed this presentation and found it very informative. We have a question here in the chat from earlier. Just bear with me. The chat. So it's from Dr. MND Pahal. Please help me here, I'm not a dentist. Isn't formocrystal no longer to be used because it is carcinogenic?
Well, some countries just say it is carcinogenic and they abandoned using it. But the article I'm reading, I'm summarizing today, is from American Dental Association for Pediatric Dentistry, and they do use it. British Council also use it. So some people just don't use it, some colleges. The schools that use it, they say use it with a precaution. That means use it for only 5 minutes and just squeeze it very well before you use it on the pulp tissue. And don't use it, we don't mix it with the paste that is going to stay in the tooth. And I know Dalhousie University use it, and I know University of British Columbia use it. I don't know about University of Toronto, maybe they don't use it. So it depends on the school itself.